All right, hello and welcome to another ONS webinar. Today we will be talking about non-surgical options for back pain. My name is Dr. Levchenko. I'm one of the interventional physiatrists here at ONS. I am boarded in physical medicine and rehabilitation, as well as pain medicine. Okay, why don't we get started? So I get asked a lot, who is a physiatrist? Well, a physiatrist is a licensed medical doctor who did training or residency in physical medicine and rehabilitation. The field really focuses on improving quality of life by increasing physical function. Through our training, we take care of patients with brain disorders such as traumatic brain injury, strokes, as well as spinal cord injuries, as well as multiple musculoskeletal problems, including neck and back pain, arthritis, sports and work-related injuries, and things like whiplash or trauma. But in the end, we really concentrate on treating the whole person and not just the problem area. So who is an interventional physiatrist? Well, as interventional physiatrists here at ONS, we concentrate on surgical, non-surgical, orthopedic, as well as musculoskeletal disorders and pain management, including treating sprains and strains, as well as arthritis, as well as neck pain and back pain, and things like pinched nerves and degenerative disc disease. We have a wide variety of treatment options available to us, such as medications. We also use minimally invasive image-guided pain management procedures, such as epidural injections and multiple joint and tendon injections, nerve blocks, including hydrodissection, radiofrequency ablation, as well as regenerative medicine. Obviously, we use physical therapy, bracing, education. We do spend a lot of time on that. And we do nerve conduction studies, also known as EMG. Well, let's talk about the back pain. So back pain is very common. 80% of Americans will suffer at least one episode of back pain in their lifetime. It's also the second leading reason for a doctor's reading and the leading reason for the work-related disability. So why do we get the back pain? There are many, many different reasons why that can happen, but the risk factors that we know of included genetics, stress, poor posture, inadequate physical fitness, obviously aging, strenuous body positions, exposure to vibration, smoking, as well as arthritic conditions such as rheumatoid arthritis. A little bit on the spine anatomy. So we have 33 vertebrae, or the little bones that make up the spine. But usually when we talk about the spine, if we talk about the neck pain, we're talking about the cervical spine. If it's the mid-back pain, we're talking about it's the thoracic spine. If it's the lower back, it's the lumbar spine. And then if you're going further down into the pelvis and the sacrum, it's the sacral as well as the coccygeal parts of the spine. We're going to concentrate on the lower back. So we're looking more at the lumbar spine anatomy right now. So what you're seeing on the right side of the screen, you're seeing the vertebra, and then between them, the blue are the intervertebral discs or the discs. Think of them as shock absorbers. On the left, you have your joints, also known as facet joints, and they're really linking up all the vertebrae together, giving the spine its flexibility, movement, as well as the strength. You have the spinal cord running through the spinal column, and then you have the spinal nerves coming out from the little openings on the side called foramina. If you take a cut through the disc, such as what you see on the MRI, that allows us to see the integrity of the disc if you have a disc herniation or disc degeneration, as well if you have any pinched nerve. You see a lot of ligaments surrounding the spine, and those really just provide the stability for the spine. Most superficially in the back, you have a lot of muscles that provide additional stability for the spine. But generally, when we talk about the spine, we want to think about the spinal unit because everything really works together. And the spinal unit includes the disc, it includes the actual vertebra, it includes the facet joints, all the ligaments, all the bones, and all the muscles that we just talked about. And that really provides the base of support for the spine, all right? You have the opposing curves in the spine. And then what that really helps, it really helps to redistribute the weight in the spine. and in such decrease the forces through the discs and the little joints and all the little structures in the spine. And if you do end up with the loss of the curve, such as when you have a head forward posture, right? And what happens is that the distribution of forces changes, and that can lead to the disc degeneration, and the disc degeneration then can lead to the arthritis in the little joints. Overall, that can lead to some instability in the spine. And that, to provide the extra stability, the spine actually forms the little spurs, and that can lead to stenosis. So it's a snowball effect, and we want to prevent that. Here on the bottom, you see a few samples of the MRI screens. And what we're looking here, we're looking at the muscles, the muscles that are providing the support for the spine. And when you look at the muscles, you want to see a lot of dark. Dark is really a good, strong muscle on the MRI. Now, if you're seeing a lot of white on the MRI, what you're seeing here on the right side, so a lot of white there, that is fat, okay? So that's the muscle atrophy. So that's what we do in physical therapy. We do strengthen those muscles, converting the fat into the muscle tissue and giving the spine extra stability that it needs. Looking at the different types of posture, you do want to be all the way on the right. You want to see the balanced posture. You want to see the neutral pelvis. You don't want to see anterior tilt or posterior tilt. You want it to be neutral. And that really offloads not only the spine, but it also offloads the stress from the hip as well as the knee joints. Let's talk about the common causes of pain. So usually someone who is a younger, 20 to 50-year-old, more often they develop different muscle strains or sprains, they develop herniated discs. They do get degenerative discs, but that's more prevalent as we get a little bit older. But they also experience more trauma, and they can end up with little fractures. They cause pars interarticularis fractures. We see them a lot in athletes. They also, younger people are actually more prone to infections and tumors as well. The older population, 50 to 70 and above, this is really where we're getting more into the arthritic changes, more of degenerative changes of the discs. And all of that can lead to the spinal stenosis, where that's narrowing of the spinal canal. You can end up with degenerative scoliosis. That's when the spine becomes unstable from all of the degenerative changes. And you can also see compression fractures that are more prevalent or more commonly seen in females, postmenopausal females. So let's talk about, so the most common, what we see in the office are the back strains or sprains, right? And there's difference to sprain or a strain. So strain is usually an injury to a spinal muscle, and the sprain is usually a ligamentous injury to the joints as well as the discs, without a disc herniation resulting in a pinched nerve. It's usually preceded by a lifting or twisting episode, but not always. Sometimes just bending over, trying to reach for something very, very light, like a piece of paper on the floor, can create a sprain or a strain. The pain usually extends to the buttocks, maybe to the posterior thighs, but usually does not cross the knee further down. And standing or any prolonged position usually quite uncomfortable. Treatment, at first we concentrate on the pain relief, and then we concentrate on return to activity. We modify the activities at first, then you start physical therapy once you can tolerate that, and then you progress to the home exercise program. The good news is that most of the patients improve just within a few days, with 80% of the patients having significant improvement in their pain within 1 month. Here I included an exercise program that is usually taught in physical therapy and that can be followed at home as well. So here you see in the kneeling back extension that looks very familiar, very similar to a child's pose. This is a very relaxing position for the back. Here's a knee to chest exercise, very simple. Side bridges, it can be tolerated. If you cannot tolerate the side bridge, then you start first with putting weight on your knee and then slowly progressing to this hold. Hip bridges are also very, very good exercises for the back pain. Now let's talk about the radicular pain, also known as sciatica or pinched nerve pain. Now this pain is usually very sharp. It feels like electricity running down the leg. It usually goes through the buttocks and goes through the thigh, and can go all the way to the calf and the foot. You may experience numbness and tingling and burnness, or the leg may feel cool. There may be even some weakness, and if you have that for a certain period of time, you even can develop atrophy of the muscles. Usually things like straining or coughing or sneezing or bearing down exacerbates the pain in the leg. Now, we also have something what's called referred pain. That's usually a very dull and kind of deep and boring pain. It's usually ill-defined. It's kind of, when you ask, where's the pain, you point, well, it's the whole back. And then when you poke around, you may feel little trigger points in there, right? And that pain, usually when you press on it, it can get referred a little bit further, but usually does not travel all the way down into the leg, what you experience with the radicular pain. Common syndromes related to trigger points or referred pain that can produce the referred pain at quadratus lumborum syndrome. Quadratus lumborum is that muscle that you see on the left with the little star. It's very common to strain or sprain that area. And when you poke around that, it can actually, you can feel the pain get referred to further down into the buttock or even into the anterior thigh. Another very common condition is the gluteus maximus syndrome. That's when you have a very tight and very painful gluteus maximus, or the buttock muscle. You put the finger there, you put a little pressure, and the pain gets referred all around and further down into the thigh. And this can be treated with something what's called trigger point injection. It's an in-office procedure. It's very simple, very safe. And here's a little picture with all the red dots that you're seeing on the screen. Those are the most common areas to develop the trigger points. As you can see, they can be anywhere in the lower back, very, very common in the upper back as well. So let's talk about the treatment. So let's talk about the medications. We have the anti-inflammatory medications, also known as NSAIDs, non-steroidal anti-inflammatory medications. It's your Aleve, it's your Motrins, it's ibuprofen, it's Advil, it's all those medications you can get over the counter. They usually work very well, but you have to be careful, right? If you have history of stomach ulcer, so you have a history of acid reflux, these medications can make it worse. Also, if you taking a blood thinning medication, then this medication is usually contraindicated. Another common medication is Tylenol, or also known as acetaminophen. It's usually well tolerated. Have to be careful if you're having some kind of liver issues, fatty liver disease. Also, it can be found in many other medications, right? So you have to be careful. You have to make sure that you're not exceeding 3 grams per day if you're taking this medication from all the different sources. Then you have your pain patches, you have your lidocaine, you have capsaicin, arnica, all of this available either in patch or cream formulation that you can get over the counter. There are obviously prescription medication. Usually prescription medications are stronger and more potent, right? We can prescribe different anti-inflammatory, non-steroidal, as well as steroidal medications. We can prescribe nerve medications. We can prescribe pain patches, as well as the opioid medications. Have to be very, very careful with the opioid medication because of the opioid epidemic. Right here, you have a opioid by the numbers, right? Lots of people dying from this, lots of problems. So we usually, we're very, very careful with these medications. We usually prescribe it for acute pain and on a short period of time. Obviously, interventional physiatrist, that's what we do. We do interventional pain management procedures. We usually use either X-ray guidance, also known as fluoroscopy, or ultrasound guidance for our injections. And as I like to quote Yogi Berra, you've got to be very careful if you don't know where you're going, because you might not get there. So you have to see where you're putting your needle. It's very, very important, not only for safety, but also for efficacy. So fluoroscopically, or X-ray guided procedures that we do epidural injections, we do facet joint injections, we do different blocks, we do sacroiliac joint injections, coccyx injections, as well as radiofrequency ablation. I have a few pictures here, right? This is an epidural injection. On the right, you can see the needle advance right next to the nerve that is being pinched and inflamed. And the medication, usually steroidal medication, is delivered right on the area of the inflammation. Here's an example of a facet joint injection when the medication, the needle is directed directly into the little joint in the back, And the medication, usually steroidal medication, again, delivered exactly into the joint affected. Medial branch blocks, those are the little nerves that supply the joints, and we can block them with just a little amount of a lidocaine. Very, very safe procedure, not using any steroidal medication. So for someone who has high blood pressure or diabetes, it's very, very safe and preferred procedure. Sacroiliac joint injections, again, you're seeing on the right, the needle is advanced directly into the sacroiliac joint. And even though this joint is quite superficial, but because it's rotated obliquely, it's very difficult to get into that joint blind. So you always have to use image guided, and usually it's fluoroscopy or X-ray guided injection. And then you have radiofrequency ablation. So as I explained to you, you can block the nerves with the anesthetic, but you can also burn the nerves. And that can give you nearly complete, up to 6 months and even longer, pain relief. Someone who has tailbone pain can be very, very uncomfortable. We do coccyx injections for those patients. Again, we use X-ray guidance for those injections. Let's talk about prevention, right? You have to take care of your back daily. You have to be very careful with your back, and the back will take care of you. You want to have strong core muscles, back muscles, hip muscles. You want to stretch your hamstrings, your quads, your hip flexors. You have to follow up proper lifting techniques, proper posture. Make sure if you're working at the desk and the computer, you have to have a proper ergonomic work area set up. Don't stand, sit, or lift for a prolonged period of time. Take breaks. Good nutrition is key, and healthy weight as well. Stress management, adequate sleep, and obviously no smoking. So here are a few quick stretches that you can do at work if you've been sitting for a long period of time. I recommend doing them every half an hour. Just get up, move around for a few minutes, and stretch. And stretch your here on the left, you see a quick stretch for your calves. On the right, you see a quick stretch for your hamstrings. Very easy to do. Gentle, you don't have to push yourself too hard. It should not be painful. On the left here, you see a quick quad stretch, also known as a runner stretch. And on the right, you see a flexor, hip flexor stretch. If you're working from home, then you can use a child's pose. Excellent, excellent position for relaxing your back and stretching your back. Very easy to do, very safe to do. Now, talking about the posture, right? So when we talk, we think, well, if it's the back pain, and it has to be only in the back. Well, not so, right? Everything is linked in the spine. Remember how I told you that as physiatrists, we train to look at the whole patient, right? So if you're having a head forward posture, it's very common nowadays with the use of the computers, tablets, the phones, you know, we're always like that. And when your head is forward, what happens, you're actually changing your curve in the spine. Not only you changing your curve in the neck, but that actually affects your curve in the back, right? So the more forward you in the neck, the more swayed back you're gonna get, and the more stress on the back that's gonna put. Not only that, it doesn't stop there, because then your pelvis ends up in either anterior or posterior tilt, right? You're creating more stress on your hips as well as the knees, and because your weight is not stacked directly over your heel, then you're developing more stress through the mid to anterior part of your foot, where you have all these little bones that are not designed to handle all that stress, and that can lead to a lot of foot problems as well. So let's talk about proper lifting, right? So if the object is too heavy, don't do it, right? Just ask for help. But if you can handle it yourself, right? Make sure that you spread your feet apart, kind of shoulder width, right? And stand as close to the object as you can, right? You really want to be lifting that very close to your body. You want to bend your knees. You don't want to bend at the waist. You want to hinge at your hips, keeping your spine straight all the way from the base of the skull and down to your sacrum, right? You tighten your stomach, you tighten your core muscles, and then you squat and you bring the object up using your leg muscles, not your back muscles, right? And also very important, if the object is to your side, don't twist and try to lift it like that. You want to turn your whole body. You want to face it on directly before you lift it up. All right, so here's an example of proper ergonomic setup at work, right? You pay attention, you want to have nice 90-degree angles at your knee, at your hips, as well as at your elbows, right? And you want your eye to hit the screen at about 2 inches below the top rim of the top of the screen. Sleeping, right? So generally, if you're having back problems, I recommend moderate to firm mattress, right? Especially if you're sleeping on your back. If you're a side sleeper, then a little softer mattress is more recommended so that you can protect your shoulder, right, and your hip joints with that, right? Generally, the stomach sleeping position is the worst and it's not recommended. If you do have to sleep on the stomach, if that's the only way that you can fall asleep, then you got to make sure that you use lots of pillows to provide extra support. Right, physical therapy and exercise very important. As we're aging, we're losing muscle mass and strength, and the physical therapy and overall staying active can really help you to maintain that muscle mass and the strength. All right, so usually physical therapy concentrates on both muscle strengthening as well as aerobic fitness, and both are extremely important. Diet, right? So anti-inflammatory diet is very important. So the less sugar, the less simple carbs we consume, the less inflammation we have in our body, right? So a Mediterranean diet is one of the examples. All right, and this says a healthy spine is the key to a healthy life. So thank you for your time and your attention. Make sure you follow us on Twitter at ONSMD and at Dr. Levchenko. And for more information, you can always refer to onsmd.com. We'll be happy to see you in the office, and have a great day.